So today we're going to talk about ultrasound in the intensive care unit, gross valvular abnormalities. And so today we will do a valvular assessment in point of care ultrasound. I have no financial disclosures. So every week we've been talking about goal directed echo, and we go through the 5 assessments in shock. So when I go to the bedside and a patient is hypotensive, the 5 things I'm looking at in my echo portion of my ultrasound assessment are left ventricular size and function, right ventricular size and function, pericardial effusion, in which I'm actually assessing for tamponade, intravascular volume status, and gross valvular abnormalities. So today we're going to talk about the gross valvular abnormality portion. And when I talk about gross valvular abnormalities, the 3 that I think fall into the area of POCUS are aortic stenosis. And this is, of course, looking for severe hemodynamically significant aortic stenosis. Mitral regurgitation, again, also looking for severe mitral regurgitation, and left ventricular outflow tract obstruction. So today we will talk about these 3. We will talk about aortic stenosis, mitral regurgitation, and LVOT obstruction. In aortic stenosis, we will talk about a qualitative assessment, so how to look at the aortic valve and assess qualitatively if you see stenosis. We'll talk about peak aortic velocity as a quantitative evaluation we can do of the aortic valve. We'll talk about mitral regurgitation, again, a qualitative assessment of if we see mitral regurgitation. And then we will learn how to do Doppler assessment of the mitral valve. We will also talk about LVOT obstruction, where we review some clinical scenarios and talk about the management of an LVOT obstruction. So let's take a second to review the anatomy of our valves. So as you can see here, we've got the mitral and the tricuspid valve here. More anterior to that is the aortic valve, and then most anterior is the pulmonic valve. I'd like to note here that this anterior leaflet of the mitral valve is very close to the aortic valve and actually the LVOT, or left ventricular outflow tract, which is what we will talk about again when we get to LVOT obstruction. You can also look a little closely and see the anterior cusp of the mitral valve, the posterior cusp, and then for the aortic valve, the left coronary cusp, right coronary cusp, and non-coronary cusp. So aortic stenosis is common. It's 2 to 3% of people older than 65 have it, and greater than 10 often have it in patients older than 80. Some important things to know about it is that you do have increased LV afterload. So this gives you a reduction in the aortic valve area, and this will give you this high aortic transvalvular gradient, and therefore an increasing left ventricular afterload. So if you look at these pictures here, we have a normal aortic valve, opens very nicely. We don't have a reduction in this aortic valve area. Rheumatic disease, we've got thickening at the tips of the leaflets, and they don't open normally. And again, you have a reduced valve area here. Calcific, again, you have calcium. It doesn't necessarily have to be at the tips, but it also restricts the aortic valve opening. And then over here, you have a bicuspid aortic valve where 2 are fused. And again, this does limit that aortic valve opening. With this concentric LV hypertrophy, you do end up with a further increase in LV filling pressures, and this will also compromise your diastolic function. So how are we going to grade aortic stenosis? Well, anytime you're assessing a heart with ultrasound, you want to have an integrative approach. Ideally, you get multiple views, use multiple methods. So we are going to use both a 2D or a B-mode view and also Doppler assessment. It's important to know that loading conditions influence the velocity and pressure gradients. So for example, when we start talking about aortic valve and assessing the aortic valve severity, we'll look at the peak velocity across that aortic valve. But if you have a low cardiac output, meaning that that heart is not pumping as much blood through it as you would like, you might not get that high velocity across the aortic valve that you would get in a normal cardiac output. So a low cardiac output could significantly underestimate your aortic stenosis severity. And just note that the goal here is to identify clinically significant aortic stenosis. And so we want to be sure we are aware of the limitations of POCUS and make sure we put everything together. And if we're just blindly calculating a number and it doesn't make sense clinically, take a second look or ask someone else for help. So qualitative assessment of the aortic stenosis. The aortic valve leaflets should coapt in the middle. So basically, our qualitative assessment is just looking at the aortic valve. Does it open? Does it close? When it closes, do they come together in the middle? Do the valves open all the way? Signs of a possible severe aortic stenosis would be that you have a heavily calcified aortic valve. So remember, calcium is going to be bright white on ultrasound. So if you see a lot of white, you see a lot of calcium, that could be a sign that this patient might have severe aortic stenosis. This would also go with MAC, or mitral annular calcification. If you see a lot of calcification at the mitral valve annulus, this might lead you to suspect that there could also be significant calcification at the aortic valve annulus. The most important here is the third one written in the third bullet point, also written in red, is minimal excursion of the aortic valve leaflets. So if you're doing a qualitative assessment, just looking at those leaflets and say, are they opening? Are they not? And if you see minimal excursion, meaning they're not moving very much, that is a sign of possible severe aortic stenosis. You can also see flow acceleration or turbulence if you put color flow Doppler. It's likely you will see a left atrial enlargement. So if you remember from our other lectures, the right ventricle should be about the same size as the ascending aorta and about the same size as the left atrium. So in these patients, you will see that the left atrium is much larger. And then you may also see concentric left ventricular hypertrophy, meaning that that left ventricle is much thicker than you would expect. So let's take a look at some videos. So for this one, our question here is severe aortic stenosis likely? This is a parasternal long access view. You see the right ventricle at the top of the screen, left ventricle, left atrium, mitral valve, and aortic valve. So if you take a second to look and think to yourself, is aortic stenosis likely? The answer is no. We do see it's calcified. We see this bright white here at the base, but you still have good valve excursion. So if you look at those leaflets of the aortic valve, you can still see that they're opening and closing nicely. So you can feel pretty confident that the severe aortic stenosis is not likely. This picture, however, this is a transesophageal echo, meaning that the left atrium here is at the top of the screen, and this is our aortic valve and short access view. We see the three leaflets, and if you think to yourself, here is severe aortic stenosis likely, the answer is going to be yes. This is a heavily calcified valve. You can see all the bright white around it. And we also have concern for aortic valve excursion. It doesn't look like these valves are opening very much. So you have significantly decreased aortic valve excursion. Another picture here, parasternal long access view again. So left ventricle, left atrium, mitral valve, LVOT, aortic valve, ascending aorta, and right ventricle. And if you look closely again at that aortic valve and ask yourself, is severe aortic stenosis likely? The answer is no. There is calcification, but you can still see the fluttering of those leaflets opening and closing, and you still see good valve excursion. Now we're going to move on to talk about a quantitative assessment of aortic stenosis. There's lots of different measurements we can do, but we are going to, in POCUS, focus on peak jet velocity. And I put it in red because I think it's worth memorizing that the peak jet velocity greater than 4 meters per second is considered severe. We can also look at mean transvalvular pressure gradient, where more than 40 millimeters of mercury is severe, or aortic valve area by the continuity equation less than 1 centimeter is severe. But again, for POCUS today, we're going to talk about peak jet velocity greater than 4 as being severe. So when we talk about peak jet velocity, what exactly is this? This is that velocity across the aortic valve. And essentially, it's a direct measurement of the velocity of blood as it goes across the aortic valve. And if you remember back to when you might be a kid and you were spraying the hose, maybe spraying someone across the lawn, and you wanted the water to go further, you covered up part of the orifice of the end of the hose, right? And you had an increased velocity of the water exiting the hose, and it could travel further. And so velocity across the aortic valve will also increase, just like water in a hose, as the stenosis severity increases. So we can use this direct measurement of velocity across the aortic valve, and it can tell us about the severity of that stenosis across the aortic valve. Again, I think it's worth memorizing that severe is greater than 4 meters per second. And this is the strongest predictor of clinical outcome, peak jet velocity. It's important to note this does require parallel alignment of the ultrasound beam to blood flow. So if you think back to our lectures on the physics of ultrasound, when we do Doppler assessments, we are looking at the velocity of blood. And in order to appropriately calculate the velocity of blood, we need to be either parallel or anti-parallel to the blood flow. So we unfortunately cannot get a peak jet velocity in a parasternal long axis view. We can use an apical 5-chamber view. Right here, we have our LV, RV. Our beam is angled slightly more anterior. Remember that aortic valve is anterior to the mitral valve. So when we angle it such that our beam goes anterior on the body, we can bring in this LVOT and this aortic valve, and we could put Doppler across the aortic valve here. You can also do an apical long axis view, in which case you would continue rotating the probe counterclockwise from an apical 4-chamber view until the right ventricle comes back in on the other side of the screen, and you get an apical long axis view. So what type of Doppler are we going to use? If you remember, there's continuous wave and pulse wave. So pulse wave gives you the velocity at a specific location, but it can't really do high velocities. So we used pulse wave in previous lectures when we were talking about the velocity of blood in the LVOT to calculate, oftentimes in POCUS, a VTI. Here, we're going to use continuous wave Doppler. So we are going to get the velocities all across this line that comes up when we press continuous wave on our ultrasound. We're not going to know where the velocities come from, but it's going to be able to give us a high velocity. And of course, if we are worried about aortic stenosis, we know there's a chance there's going to be a high velocity across the aortic valve. So we're going to get all the velocities here. And we don't need to know where they're coming from because we know the highest velocity is going to be at the short or the smallest area, right? At the most stenosed part, which we know that's not going to be over here in the left ventricle or over here in the ascending aorta. We know that it's going to be here across that aortic valve. And so again, to get an apical 5-chamber view, which is where I'm often doing this, you're going to get an apical 4-chamber view, LV, RV, LA, RA. You're going to tilt the tail down so that your beam goes more anterior on the patient, and you will get this LVOT and aortic valve to come out, and you can put continuous wave Doppler across the aortic valve. So again, for a quantitative assessment of aortic stenosis, we're going to get peak aortic velocity. So when we had this picture here, we are looking for blood going across the aortic valve. So the blood is going out this way. So it's going away from the probe. So it's going to be a negative Doppler shift. So if this is my line, I might need to move it, knowing that my blood is going to, my Doppler shift is a negative Doppler shift, and I'm looking for my little hill or hump or however you want to think about it here in systole. So again, I'm putting continuous wave Doppler across the aortic valve. Because we're in continuous wave Doppler, I know that we're going to get a filled in waveform. So this waveform should be nice and solid to be sure that I'm getting a good tracing. If it were in pulse wave, it should be black in the middle because I'm getting a specific location. But again, here, because this is continuous wave Doppler, this is all filled in. And what we're going to do is, if we're measuring Doppler, it's velocity over time. So our x-axis is time and our y-axis is velocity. So if you look at this, this is meters per second. This is 8 down here. So this is our meters per second and our velocity. So we're just going to put our little cursor here at the top of our hill or our waveform, and we're going to say, what's this velocity? And so here we did that, and the velocity is 5.4 meters per second. So we remember that severe aortic stenosis is greater than 4. So again, if you put continuous wave Doppler across this aortic valve, we know that we have clinically significant aortic stenosis. This is a study evaluation of systolic murmurs using transthoracic echocardiography by anesthesia trainees. So this is a study they did. They thought it was important because aortic stenosis increases the perioperative risk in non-cardiac surgery. So it's something you might want to be aware of course, either in a pre-op clinic or if you're on call overnight and doing an urgent surgery, it might change your induction plan. They had 5 trainees. They only did 2 hours of didactic and hands-on teaching and evaluation of the aortic valve. They scanned 20 patients each. And then they asked them to say, what is this clinically significant aortic stenosis? And they compared their results with a cardiac anesthesiologist who had formal echocardiographic training. And what they found was with just 2 hours of training and 20 patients, they had an agreement between the consultant and trainee of clinically significant aortic stenosis based on peak aortic velocity. And they used more than 3 meters per second as their cutoff. So this is just to show that this is important to your field, I believe, and it's easily done. So management of aortic stenosis, I'm sure you're familiar with this. Of course, we need to remember that these patients are preload dependent. They have an increased LV afterload, and diastolic volume is important. They do have elevated LV filling pressure. So we're going to avoid tachycardia, avoid hypotension, and avoid arrhythmias. So our ideal heart rate is going to be 60 to 90. Because if they're too tachycardic, we're going to end up decreasing their diastolic filling time, and we're going to increase their myocardial oxygen demand. Hypotension volume repletion is often necessary if they're hypotensive. And if they're hypotensive after fluid, they may need vasopressors, of course. Alpha agonists may be preferred to beta agonists. So phenylephrine often can be first line, but norepinephrine is also reasonable. But you're probably going to want to avoid epinephrine and more inotropic support in these patients when they're hypotensive. Arrhythmias, of course, we really want to maintain normal sinus rhythm if possible, because the atrial kick is really needed for preload. So consider cardioversion early in these patients. And of course, if pulmonary edema, non-invasive positive pressure ventilation is a great choice. We're going to move on to talk about mitral regurgitation. So again, we're going to do both a qualitative and a quantitative, or qualitative really and color flow Doppler as my quantitative aspect. So from a qualitative perspective, the questions we're going to ask ourselves are, do the leaflets coapt? Are there vegetations? And are there flail leaflets? And if we put color flow across the mitral valve and the left atrium, the questions we're asking ourselves are, how wide is the jet? And how far does this jet go into the left atrium? And of course, the goal is to evaluate for severe acute mitral regurgitation. So oftentimes, we're also keeping on our differential or thinking about significant ischemia or endocarditis. So again, this is a apical 4-chamber view, LV, RV, LA, RA, with color flow Doppler. You see you have it against or kind of across the mitral valve, and it goes into the left atrium. And if you look at this picture, the questions we're going to ask are, how wide is the jet? And at the end of the video, you can kind of see it's frozen, and it's nice because it shows us really this jet. And so I would say that this jet here is not very wide. And the next question is going to be, how far does the jet go into the left atrium? So again, it goes here. But my answer to that is going to be, it does not go very far into the left atrium. So this here is an example of mild mitral regurgitation. So again, not something from a POCUS standpoint I think is deteriorating to my patient's hypotension. Here we have another picture. Again, this is Doppler across the mitral valve. So here's my left atrium. So here we're looking at this jet here. And our questions again are the same. How wide is the jet? So if you look at this jet distance here to here, again, we're just kind of looking qualitatively. We would say this jet is very wide. It looks pretty big. It also has some turbulent flow. You can see some aliasing. It's not just that blue color, but you see the yellow and the light blue. And the next question is going to be, how far does the jet go into the left atrium? And I would say it probably goes outside of where this box is even measuring, and it extends pretty far into the left atrium. So this is going to be an example of severe mitral regurgitation, and this, of course, could be contributing to your patient's decompensation. This is another picture. It's a transesophageal echo. So we see the left atrium at the top. Here's our mitral valve, and here's our left ventricle. And if you look at the mitral valve, this is endocarditis. You see a large vegetation here on the mitral valve. So this, again, of course, could be contributing to is likely, I guess I could say, contributing to your patient's decompensation. All right, now we're going to move on to our next section. We're going to start with a case. So this is a case I had. An 83-year-old female has a history of hypertrophic cardiomyopathy. She was admitted to the floor with weakness. She arrived on the floor hypotensive. Her blood pressure was 183/96. She was given hydralazine, 5 to 10 milligrams, and all of a sudden she became hypotensive. Her blood pressure was 54/36, and she says, oh, I have some chest pain. So this was at a hospital where the EICU would respond to the rapids. They responded and they saw that she had a blood pressure of 54/36. Her heart rate was 30. They got an EKG. It had T-wave inversions and ST depressions in the lateral leads. They ordered a troponin and they ordered some IV fluids and dopamine. And they called me and said, the patient's coming to the unit for a line and pressors and concern for an MI, an inferior MI, given the hypotension and bradycardia or relative bradycardia in the setting of hypotension. And my initial thought was, yikes, I don't know about that. So I called the nurse immediately and I said, please do not give the dopamine, give the fluid faster. Only 100 cc's had been given, and I went to do a bedside ultrasound. And what did I find? An LVOT obstruction. So this is not her exact ultrasound, but this is an example of what I potentially could have found, or what I could have seen, or an example of what I did see. So this is the left ventricular outflow tract obstruction, which is also here systolic anterior motion of the mitral valve. So this is a peristernal long access view. We have a left ventricle, left atrium, mitral valve, LVOT, aortic valve. And if you look here at the arrow, you see that that anterior leaflet of the mitral valve is being pulled into the LVOT during systole. So left ventricular outflow tract obstruction, this is often caused by SAM, meaning that it's caused when you have a systolic anterior motion of the mitral valve obviously during systole, right? So that anterior leaflet sucks into the LVOT and obstructs the blood that's trying to exit the LVOT. And how this often happens is sometimes it's just any sort of structural change in the heart makes that LVOT smaller. And so we talked about when an area is smaller, the blood is going to flow through it quicker. And so what happens is you have hypertrophy, whether it's HOCM or just general LV hypertrophy. You have hypertrophy of the left ventricle. That makes your LVOT smaller. So when that LVOT is smaller, again, we said blood is going to flow through quicker. And when it does, that quick flowing of blood through the LVOT kind of sucks in that anterior leaflet of the mitral valve. So basically, fast flowing blood through the LVOT pulls that mitral valve anteriorly. So if you just remember that as the principle, anything that can cause that blood to go faster through the LVOT puts you at risk for an LVOT obstruction with SAM. So again, by definition, an LVOT obstruction is a pressure gradient across the LV outflow tract greater than 30. So this is a transesophageal echo. Here is our left atrium, left ventricle, LVOT. And here you can see this is an example of SAM, or systolic anterior motion of the mitral valve. So oftentimes when you have an LVOT obstruction or SAM, you have both predisposing factors, predisposing anatomical factors. So remember I said anything that can cause that LVOT to be smaller. And then you have these precipitative factors. So some of our predisposing factors, the most common is hypertrophic cardiomyopathy, but really even LV hypertrophy, aortic stenosis or hypertension, myocardial infarction, mitral valve replacement or repair, ballooning syndrome, so Takotsubo, sigmoid septum, steep aortic root angle, abnormal mitral subvalvular apparatus, acute cor pulmonale, and atrial fibrillation. But it's important to note that predisposing factors are not required. And like I said, even just LV hypertrophy, which a lot of patients have, can be considered a predisposing factor. So then if we look at our precipitative factors, decreased preload, so hypovolemia or bleeding. So in the operating room, you guys often see bleeding, of course, right? Decreased afterload. So vasoplegia due to general anesthesia for you guys in the OR, maybe me, septic shock in the ICU. And then LV hyperkinesis, right? So if they have dobutamine infusion or just even tachycardia. So again, add a possible predisposing factor and then a precipitating factors, and you're at risk for an LVOT obstruction. And of course, remember, predisposing factors are not required. So this is our vicious spiral again of the LVOT obstruction. So again, we have anatomic substrates, we have physiologic substrates, and then we can end up with a dynamic LVOT obstruction. So our anatomic substrates, remember we said small cavity size. So LVH due to hypertension or hypertrophic cardiomyopathy, but it could just be that the patient's hypovolemic, right? And now their LV cavity size is small. Or oftentimes you can have apical hypokinesis, So you have an LAD ischemia, and that apex of the heart is not moving. And so then maybe the base of the heart is going to become hypercontractile. And that could also contribute to systolic anterior motion of the mitral valve, or Takasubos again, because that base is working, but you have that apical ballooning. And then again, the physiologic substrate. So really any factors that make the LV hyperkinetic and underfilled. So preload decrease, so hypovolemia, bleeding, decreased afterload, so sepsis or vasodilators, and then increased heart rate or increased inotropy. And of course, you can just have a high endogenous sympathetic tone. And this again can lead to that dynamic LVOT obstruction where the patient's hypotensive. Maybe they're getting inotropes and diuretics, that's going to worsen it, and you can end up in this spiral that ends up in cardiac arrest if not intervene quickly enough. This is a study, dynamic left ventricular outflow tract obstruction, underestimated cause of hypotension and hemodynamic instability. And in this study, they said that left ventricular outflow tract obstruction is the third most frequent cause of unexplained hypotension. So again, when I'm going to the bedside in a hypotensive patient with my ultrasound, I'm remembering that this is, if I don't see anything else on my ultrasound, LV function, RV function, tamponade, hypovolemia, right? I'm also jumping to look for LVO tract obstruction and make sure that this is not a reason my patient's hypotensive. So how are we going to evaluate for LVOT obstruction? Oftentimes the views I'm looking at are parasternal long axis, apical 5-chamber, or apical long axis. Parasternal long axis is my favorite, but really any view where you can visualize the left ventricular outflow tract and the mitral valve will work, because you're looking again to see if that anterior leaflet of the mitral valve is entering the LVOT, the left ventricular outflow tract, in systole. So this is a parasternal long axis view. This patient has severe hypertrophy and also significant hypertrophy of the septum as well, so probably some HOCM. Left ventricle, left atrium, mitral valve, LVOT, aortic valve, ascending aorta, right ventricle. And there you can see they have anterior leaf motion of the mitral valve causing LVOT obstruction. This is left ventricle, left atrium, anterior leaflet, LVOT. This is an apical 3-chamber. So again, you're going to be looking to see if the anterior leaflet of the mitral valve is being pulled into the LVOT during systole. And so again, here you do see that during systole, that anterior leaflet is being pulled into the LVOT. Another evaluation you can do, rather than just qualitatively looking, is an M mode evaluation. So if you remember, M mode is motion mode. So we're going to put a slice of you're going to put a slice through your ultrasound image, and you're going to look at motion over time in that slice. So time again is on the x-axis, and now motion is on the y-axis. And so we're putting this across the mitral valve. And you can see here, here's the E wave and the A wave of the mitral valve. But here, when it's in systole, and this is supposed to be open, or clear, I guess, with a nice quiet, I like to think of the mitral valve as being quiet and calm and closed. You see that there's artifact here because it's being sucked into the LVOT. And so again, this is an M mode across the mitral valve, and the white arrows are showing areas where that anterior leaflet of the mitral valve is being pulled into the LVOT. So if we want to compare two M mode tracings across the mitral valve, here are two different tracings across the mitral valve. And if we look at them, we see the E wave in both, or early diastole. That's when that mitral valve is opening up and it's getting really close to the septum if you have good LV function and the blood is rushing into the left ventricle. And then we have the A wave, which is late diastole, or that atrial kick, really. And then here we have systole in both. And so one of these looks like the slide prior, and one of these looks different. So this one on the bottom here, I would call this one calm and quiet. Here's our anterior leaflet of our mitral valve. We see a nice line where that mitral valve is coapted nicely. And above it, we see an area of black or anechoic, which is where blood is. So this is where our blood is flowing through the LVOT, and it's open essentially. Versus here, we see that anterior leaflet, this is creating some artifact or some movement, and that anterior leaflet is being pulled into that LVOT. And so this top one is an example of SAM, or systolic anterior motion of the mitral valve. And this bottom one, we can see that there's no SAM, or no systolic anterior motion of the mitral valve. When we put the continuous wave Doppler across the left ventricular outflow tract, we can sometimes get different velocity curves. So I just wanted to point out, this is going to be our velocity curve if we have aortic stenosis, and here would be our peak velocity, 3.6. Versus if you put a velocity curve across a valve where you have SAM, this one specifically is hypertrophic cardiomyopathy, you see that there's what's called a later maximum velocity, or late peaking. So here you have the increase in velocity, and then later in the cycle, you have this increase or this peak. And so it looks a little different, kind of like a dagger, where instead of having a nice curved hump or curved top like this one, it starts to curve up and then it daggers up. And this is consistent with LVOT obstruction. So again, just note these different shapes of the velocity curves. And in the second one, where you have an LVOT obstruction, you see a later maximum velocity with dynamic obstruction. So again, that left is moderate aortic stenosis with the peak velocity being 3.6. And the right is a dynamic outflow obstruction and hypertrophic obstructive cardiomyopathy. Just some more pictures again of LVOT obstruction. So left atrium, left ventricle, and you can really see this anterior leaflet is being sucked in. You can it almost looks like a 90-degree angle as it's sucked into that LVOT. This is just another example of LVOT obstruction where you put Doppler over and you can see that there's really high velocities because of that turbulent flow. And so those high velocities are when you see these colors at the end of the spectrums here. Again, just another example, parasternal long axis view, left ventricle, left atrium, mitral valve, LVOT, aortic valve, ascending aorta, right ventricle. And you can see again that that anterior leaflet is being pulled into the LVOT during systole. So this is hypertrophic cardiomyopathy with SAM and obstruction to flow. So what do we want to do about this? Our management is going to be increase our afterload, increase our preload, decrease our heart rate, and decrease our left ventricular contractility. So you're going to want to stop vasodilators, stop your inotropes, and stop your diuretics. And you're going to want to give pure vasoconstrictors, give phenylephrine or vasopressin, give fluids, and in the right clinical scenario, you may decide to give beta blockers. So if we go back to the case again, this was a lady who had a history of hypertrophic cardiomyopathy. So we already know she has a predisposing factor. She was initially hypertensive, right? She was given a vasodilator and now is hypotensive. And then we find out that she has an LVOT obstruction. And we definitely don't want to give dopamine, right? Because if we look at how we would treat it, we want to avoid inotropes. All right, so topics for today's discussion. Again, we talked about gross valvular abnormalities, aortic stenosis, mitral regurgitation, and LVOT obstruction, or SAM. For a qualitative assessment of aortic stenosis, we ask ourselves, do the valves open? For peak aortic velocity, we put continuous wave Doppler across the aortic valve, and remember that more than 4 meters per second is severe stenosis. For mitral regurgitation, a qualitative assessment is, do the leaflets coapt? Are there vegetations? For Doppler, you're going to put Doppler across the mitral valve into the left atrium, and you're looking at how wide is the jet and how far does it go into the left atrium. And then for LVOT obstructions, or SAM, again, in our clinical assessment, we want to look for the mitral valve, anterior leaflet of the mitral valve in the LVOT, the left ventricular outflow tract during systole. And remember, your management is going to be to give fluids and use pressors over inotropes. Thank you very much.